بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Today our talk will be about the abdomen. The most important cases in abdomen is hepatomegaly, hepatosplenomegaly, and splenomegaly alone, and renal abdomen. The first question might be, in a case of hepatomegaly, what are the causes of hepatomegaly? The first cause may be alcohol. The second, viral hepatitis, hepatitis C and hepatitis B, may be due to autoimmune hepatitis like primary biliary cirrhosis and sclerosing cholangitis, and autoimmune hepatitis might be due to bilharzia infestation, might be due to metabolic disease like Gaucher disease, might be due to drugs like methotrexate. The second common case is splenomegaly. And what are the differential diagnosis of splenomegaly? Depend on the size of the spleen. If it's huge, you have to put the differential diagnosis of chronic myeloid leukemia and HIV, malaria, and Kala-Azar. If it mild to moderate, you have to put the differential of portal hypertension due to liver infection, due to any of the causes that mentioned before, due to hematological malignancies, due to hemolytic anemia, and due to Feltis syndrome. What are the investigation in any case in the abdomen cases? Basic investigation would be complete blood picture to look for anemia, to look for leukocytosis, to look for iron deficiency anemia, A and polycythemia, ASR and CRP to look for infections or inflammation signs, urea and electrolytes, to look for kidney function, to rule out hepatorenal syndrome as an example. And investigation for the cause, you will do hepatitis serology for HPV and for HCV. You will do autoimmune profile to exclude autoimmune hepatitis, primary biliary cirrhosis, sclerosing cholangitis, iron profile to exclude hemochromatosis, copper profile to exclude Wilson disease. The scans, you would do abdominal ultrasound to diagnose, and abdominal ultrasound if you suspect any other lesion in the liver like malignancy, one of the causes of hepatomegaly. Then screening for complications, you would need abdominal ultrasound every 6 months, alpha fetoprotein every 6 months, and endoscope for varices. In case of ascites, you would say the last investigation plus paracentesis for cytology, for culture, and sensitivity for white cell count, and for chemical to know what is SAG is. If SAG is more than 1.1, it's transudate, like renal failure, like cirrhosis, and if SAG less than 1.1, it's exudate, like malignancy, TP, and pancreatitis. The imaging for ascites, you would do hepatic vein and portal vein Doppler to look for Budd-Chiari syndrome, exclude Budd-Chiari syndrome, and the coagulation profile. In case of hepatomegaly, you would add blood film to look for malaria. You would add PT2 microglobulin to look for amyloidosis and HIV test. The scan to be added, these investigations to be added to the basic investigation we have just mentioned. The scan would be chest X-ray and axial scanning, and you would take biopsy from lymph node or biopsy flow from bone marrow. The treatment in any case, in abdomen cases, it would be non-pharmacological and pharmacological and surgical, or non-specific and specific and surgical. A non-pharmacological or non-specific would be patient education, patient counseling about his condition, vaccination against encapsulated organisms like meningococcus and pneumococcus and H. influenza, and against HAV virus and HB virus. You would stop alcohol because it's an affection on the liver. You would give the patient the nutritional and social support. The specific or the pharmacological treatment, you should treat the cause according to the case you are facing. Treatment for the complication like beta blocker, prophylaxis against esophageal bleeding or esophageal varices bleeding, lifelong antibiotic after spontaneous bacterial peritonitis. The surgical treatment is liver transplant, and it would be in case of intractable pruritus in primary biliary cirrhosis. The indication for liver transplant would be in intractable pruritus in primary biliary cirrhosis, in extreme fatigue in primary biliary cirrhosis, in recurrent cholangitis in case of primary sclerosing cholangitis, in case of bilirubin more than 50, and in acute paracetamol toxicity. To add with ascites, if the case under your hand has positive shifting dullness, has ascites, you should add fluid and sodium restriction, diuretic like spironolactone and Lasix, paracentesis with or without albumin replacement. The most common case in UK and in Malaysia is renal abdomen. Renal abdomen. The question you have to answer while you are examining the renal abdomen: what is the current mode of renal replacement therapy? Is it peritoneal dialysis? Is it renal replacement? Is it renal transplant? Is it hemodialysis? The previous mode of renal replacement therapy, the advocacy of renal replacement therapy. Does the patient has any increase in his GVP? Does he have any final spasmodic crepitation on his hip pack? Does he have any volume overload or ankle edema? The complication of the renal replacement therapy and the complication of renal failure. The complication of renal failure is mainly anemia. You should look for anemia in renal abdomen, and the etiology of renal failure in the case you have to search for. So what are the causes of renal affection? Diabetes mellitus, glomerulonephritis, hypertension, autosomal dominant polykidney disease, analgesic nephropathy, and reflux nephropathy. The most three common causes are diabetes mellitus, glomerulonephritis, and hypertension. In addition to autosomal dominant polykidney disease, analgesic nephropathy, and reflux nephropathy. What are the indications for renal replacement therapy? If eGFR less than 15, if the patient has uremic pericarditis or uremic pleuritis or uremic encephalopathy, if he has refractory hypertension, refractory hyperkalemia, refractory acidosis, and refractory volume overload, and if the patient is toxic and there is a need for toxin removal. What are the complications of renal replacement therapy? In case of hemodialysis, the most common complications are ABCD, amyloidosis, bacteremia, coagulopathy, and dialysis washout. The most common complication in peritoneal dialysis: ultrafiltration, bacterial peritonitis, complication locally, and secondary diabetes mellitus. What are the complications of kidney transplant? Rejection on acute and chronic rejection, long waiting list, complication of the procedure itself, and long life immunosuppressant. One of the critical questions they ask in the exam in case of renal abdomen, and actually we find ourselves hesitated to answer this question. Just put your headlines and then complete. It would be non-pharmacological, non-specific, and pharmacological and surgical. Non-pharmacological: patient education, counseling, vaccination, stop smoking, nutritional and social support. Pharmacological, which is critical in this case: cessation of nephrotoxic drugs, control of hypertension, control for cardiovascular risk, Treat the complications. What are the complications will be in any patient with problem in his kidneys? Volume overload, hyperkalemia, hyperphosphatemia, acidosis, osteodystrophy, and anemia. Again, the management, non-pharmacological and pharmacological. Non-pharmacological, patient education, counseling, vaccination, stop smoking, nutritional and social support. And the pharmacological would be in cessation of nephrotoxic drugs, control of his hypertension, control of cardiovascular risk, treat the complications like volume overload by Lasix, hyperkalemia, and hyperphosphatemia by phosphate binders, acidosis by bicarb, osteodystrophy by calcium and vitamin D, and anemia by iron and EPO. This is the bullet for abdomen. It's abbreviated one. If you like the video, please share it, or just give me a sign that this video is okay with you. Thank you, and see you in the next bullet.